we are so excited to have Joyce Ho with us. Joyce is an assistant professor in the computer science department at Emory. She received her her Ph.D. in electrical and computer engineering from the University of Texas in Austin, and an MA and BS in electrical engineering and computer science from MIT. Her research focuses on the development of novel machine learning algorithms to address problems in healthcare, such as identifying patient subgroups or phenotypes, integrating new streams of data, fusing different modalities of data, for example, structured medical codes and unstructured text, and dealing with conflicting expert annotations. Her work has been supported by the NSF, including a Career Award, the NIH, the Robert Wood Johnson Foundation, and Johnson & Johnson. And without further ado, I will hand it over to you, Professor Ho.
Thank you so much. And thank you all for the invite to give a talk today. So today I'm going to talk about improving prediction for 30-day hospital readmission for patients with heart failure through the integration of neighborhood level measures. So I'm sure you guys are much more familiar with this than I am, but what the natural question is, what is heart failure, that I would get asked from a computer science perspective. And it's really just thinking about not having enough blood pumped through the heart. So why should we care, I'd say, right? So if you think about getting diagnosed with heart failure, there's about a 50% mortality risk within the first 5 years of diagnosis. And then probably more, the reason why I got invited for the talk today was there's a lot of persistent racial disparities in heart failures. And in particular, Black adults have higher risks of morbidity, mortality, and hospitalization. So really thinking about adverse outcomes occurring predominantly in the Black adults. So then in thinking about what's been done to date and current clinical approaches, really the hypothesis is that we're really failing the most vulnerable populations. There's thousands of preventable hospitalizations, and more than $25 billion are spent annually in trying to treat heart failure. And in particular, what sort of has me really interested is that neighborhood level social determinants of health are widely accepted as drivers of these adverse outcomes, yet we still don't quite understand exactly what it is about the neighborhood that is causing these adverse outcomes in particular. And so we just had this idea that, really there are these unknown factors. There's data that supports this hypothesis, but can we really dig deeper and better understand, well, what exactly is it about neighborhoods? So hopefully my talk today will give you some ideas to some of the work my group and collaborators have been doing along this front. So I first want to just back up and think about, well, we have this data that suggests that there are these neighborhood level factors that are occurring, and how is it typically measured? So there's 3 common neighborhood level indices that are used. One of them is social deprivation index. So this one looks at 7 characteristics in the American Community Survey. And for those of you that may not be that familiar with the ACS, it's really looking at the 5-year census surveys that are conducted across the US. And it's capturing some of the statistics from that and then summarizing it in some form. And so these include things like, what percentage of the population is living in poverty at that census tract? How many of them are single parent households? How many of them have less than 12 years of education? So in other words, below high school level. And then looking about those without a car and unemployment. And if you look at SDI, so what I'm showing you is what it looks like across the US. And what you may be shocked to learn, or maybe not shocked, is that here in Atlanta, you notice Georgia is quite red, which suggests that on the SDI index, we are actually performing quite poorly. Now, another really common one is also area deprivation index, and this is called the ADI. It uses 17 block group indicators. So this is at a finer granularity than SDI. And it also captures data and features from the American Community Survey. ADI has really gotten a lot of popularity in the last couple of years. CMS has been using it a lot for its risk adjustment. So if you look at ADI, this is what it looks like in terms of the map. And you can see, it in fact is much finer grained, but a little bit more diverse in terms of, the range of measurements across the board. Another really common one is also social vulnerability index. This was put forth by the CDC a couple of years ago. And it's really looking at 15 characteristics along 4 themes. So looking at socioeconomic status, household composition, disability, minority status and language, and housing and transportation variables from the ACS. So you can see it encompasses a few more things, but it's still looking at very much trying to get at neighborhood level. And if you look at it in terms of, what SPI looks like across the US, it's also showing you on the right. So you can see across the 3, generally high risk areas or where we think neighborhood deprivation is large, they all predominantly agree on it. A lot of the changes are sort of in the rural areas where there might be some minor differences in terms of what each index is capturing. So in terms of these 3 indices, I also wanted to layer in how it relates to thinking about heart failure. And so this is some work that was done by my collaborators a couple of years ago, which is looking at heart failure readmissions and mortality in Black patients. And I wanted to just quickly summarize, what they're using to measure neighborhood deprivation, which is SDI. What is the population of Black, which is 53%, and then summarizing what are the big findings. And so in this paper, what they found was that the adjusted risk ratio of having heart failure, readmission, and mortality is 1.45 larger in Blacks than whites. And this is going sort of in chronological order in terms of when it was published. So in 2022, there was this nice article looking at the fact that you, in fact, can build better models using SDOH, and they will perform better than traditional models that we think of. And what they're thinking of in terms of SDOH variables are IRS income, SDI, SVI, and then also this distressed communities index that you can layer in as well. Now, one of the more interesting things is this was in the Get With It program, and so it's about 19% Black. And what they achieved in terms of predictive performance was 0.76. But if you look at the variables that they're looking at, it includes demographics, medical history, echocardiogram, electrocardiogram, a bunch of vital signs, laboratory, and biomarkers. Now, probably more related to what we're thinking of is this notion of fairness in looking at heart failure length of stay. This is also using roughly the same cohort, the Get With It program, and they're layering in SDI and ADI. And based on their, how they define their population, they got to 22% Black. They tried a bunch of models, right? And so what I'm showing you is the range in terms of predictive accuracy, ranging from 0.576 for naive Bayes to random forest getting 0.680. And then more recently was, looking at the same idea of heart failure outcomes, same data set. They're layering in 6 American Community Survey data variables, 21% Black, and they were just looking at, in particular, neighborhood socioeconomic status. There's a 1.28 higher risk of getting heart failure outcomes adverse when you're looking at these neighborhoods with these higher indices of SPS, compared to if you live in one that has the lower deprivation. So what I hope you take away from all of this, right, is that essentially it's a really hard problem, right? Even if I include a lot of information, probably the best that you can get looking at very good registry data is 0.76. But only in one of these existing work has it really looked at a population that is, I'd argue, quite diverse, where we can better understand, well, what's the predictive performance in looking at comparison of Blacks versus white. So what I'm going to focus on today is, let's say that I have this diverse patient cohort, right? I'd like to build this machine learning model for thinking about heart failure prediction. And in particular, we're going to think about 30-day readmission. What I'm really going to focus on today is how we can think about neighborhood level measures and incorporate it to get better. And in particular, I'm going to summarize 4 of the works that my group has done. And I want to highlight that a lot of this is really ongoing work. So it's not stuff that has been published yet to date, but many of them are currently under submission or in draft form. So the first thing I want to cover is thinking about well, can we better leverage existing SDOH databases? Another one is thinking about, well, let's assume that I want to layer in additional information. What are new data streams that we can think of including to capture neighborhood level measures, and do they work? And then assuming that, clearly you can do this, right? How might you integrate multiple data streams together? How would you deal with duplicate information or unique information? And then the last part is, I have these new SDOH factors. Can I think about refining them to get finer grained measurements of neighborhood level? And so I'm just gonna touch through all of them and give a broad introduction to them. I'm happy to talk more details, but I think for the purpose of today's talk, I was hoping to cover all of them at a very high level. And before I really dive in, I just want to say, if you have any questions and you want me to stop, I'm more than happy to take them either during the talk or at the end. I'm sort of indifferent either way. So I first want to highlight one of the unique benefits of being at Emory, which is that we sit on a very diverse patient population. And if we look at the heart failure patient cohort, what we can look at from 2010 to 2018, for adult patients that are admitted with heart failure, we get about 30,677 geocoded patients. And that means that, we can in fact actually have more. It's just those that we can resolve into census tracts or census blocks is just a smaller subset. One of the things that is useful to notice, right, is that I'm showing patient statistics on the right. You'll in fact notice that about 52% of our population is in fact Black. So we actually have more Blacks than whites. And the 30-day readmission rate for primary discharge or secondary discharge of heart failure is 13.8% in whites versus 20.7% in Blacks. Now I'm showing also some of the statistics in terms of where they range and differ from one another. But probably what I want to highlight is these bottom 4 statistics, which is to suggest that neighborhood deprivation is in fact higher for Black patients that come through Emory. And in fact, Emory also has about 1,800 census tracts. So in terms of the patients that it's drawing from. And so it really does encompass a lot of Georgia. Only about 800 census tracts are covered within our hospital system. But you can see, right, if you look at clinical characteristics, there are some subtle differences between the two, but probably really where they're quite different is in terms of thinking about neighborhood deprivation. So I want to walk through the setup that I'm going to use for much of all of the 4 sections that I'm going to cover. Throughout much of it, I'm going to think about baseline patient care features, and this is going to include demographic, which is age, race, gender, and insurance type, the type of heart failure that the patient has, systolic, diastolic, or other. And then we're going to just quickly summarize their clinical characteristics using the Charlson Comorbidity Index. I'm going to note that we have tried layering other additional information. In terms of predictive value, there isn't much offered, and dealing with missing data is actually the more difficult part of doing it. And so this allows us to keep many of our patients for the analysis without dropping any. And what we're going to do for this first section of the talk is we're going to compare various SDOH databases that exist to date. And what we did is we ran logistic regression, random forest, and XGBoost models. There are very little differences amongst the 3 models. So unless I say otherwise, I'm going to stick to logistic regression just for ease. We're going to do tenfold cross-validation, so evaluating it, in terms of test AUC, area under the receiver operating characteristic curve, which I'm going to denote as AUC. So this is just sort of the setup that's going to be common across the board. So I want to first compare, what we traditionally are using in terms of capturing neighborhood deprivation index. And so what I'm showing in this plot is I'm going to plot the performance in terms of the Black patients versus the white patients. So you notice Black is in green, white is in orange. So you can see, age and gender, there isn't much of a difference between the two. If I layer in demographics, it's more useful. I get slightly better predictive performance for the Black patient population. And then clearly, as I layer more, patient characteristics, I'm doing better. Now, what I really want to highlight, right, is that the trends that I'm showing, this is consistent through all three models. And I'm just showing logistic because it in fact has the smallest range in terms of performance variance. So here, I'm going to focus on the clinical characteristics. And this is a simple version of comorbidity, which is only going to look at maybe 5 or 6 comorbidities like diabetes, hypertension, whereas Charlson comorbidity index, is sort of more exhaustive. And what you'll notice, right, is that there is actually a small prediction difference based on clinical characteristics. This means that if I was to look at the performance both in terms of Black and white, it wouldn't necessarily matter much what race you're from. Now, sort of the more interesting ones are these ones on the bottom right, which are meant to capture these neighborhood level effects or neighborhood measures. And what you in fact will notice, right, is that the neighborhood effects seemingly have higher predictive value for Blacks. Whereas for white patients, this is in fact doing worse than random chance. So clearly there's something sort of interesting that is being borne out in this data. And so we really wanted to better understand this. But using the existing neighborhood level effects may not be very useful, or these traditional measures aren't very useful in understanding it. Because even if we were to layer it on, it provides very little predictive value. So I want to first cover the AHRQ SDOH database. It in fact contains SDOH features from 2009 to 2020. It contains it at 3 different levels, so census tract, county level, and zip code level. So just rolling up in terms of fine grained to coarser grained. If I'm going to stick to the middle, which is county level has about 1,307 features that are divided amongst 5 different categories. So this is looking at social context, economic context, educational context, physical infrastructure, and healthcare context. And someone over there actually defined all of them. And you'll notice that in fact, healthcare context has the greatest number of features. So we ran a correlation plot, Pearson correlation against the demographic features of the Emory heart failure patient cohort. And I'm showing you it to the right. So you'll see the top chunk is AHRQ, then looking at ADI, SVI, and SDI. And you can sort of see the breakdown of them. What I want to highlight is that SDOH features are only moderately correlated with Black patients. If you look at some of the other characteristics, they're almost close to 0, right? So that suggests that only for Black patients does these SDOH features seem to have some predictive value. For everything else, probably there isn't much information to be had. The other thing that I want to highlight a little bit as well is that AHRQ, the variables look quite different, I'd say, than ADI, SVI, and SDI in terms of information it's capturing and its correlation with the Black patients as well. So the colors of the circles and the hue is just suggesting that some are more correlated than others. But the more interesting thing is to look at how big is the circle versus how dark it is, I'd say. So this is AHRQ, and I can see that there's a question. So if someone doesn't mind telling me it, I'm happy to answer it now.
Apologies, I'm Greg. Thank you so much. Are you linking your data at the county level for the features, or is this at the census tract level for this particular analysis?
For this particular analysis, the Pearson analysis, I'm showing you county level. We in fact linked it at the census tract level, and it'll become a little bit apparent in about, I want to say 4 or 5 slides, why I'm not going to present the census tract level. But we do have it linked both at the census tract and the county level, and we've explored both of them simultaneously.
Thank you.
So, oh, no problem. So that is AHRQ. Separately, also, we've been quite interested, well, maybe we can actually capture other sort of SDOH factors. And in particular, we wanted to focus on neighborhood level of measures that maybe not commonly explored. So what we looked at is the EPA's air quality system. It provides a yearly summary from 2009 to 2020, and it contains 15 features on air pollutants at the county level. So this includes PM 2.5, PM 10, nitrous oxide, days with good air quality, days with bad air quality, and a whole bunch of others. And what I want to highlight here is that AHRQ has EPA variables. So it's the section in the top right there. And then if you look at the correlation also in thinking about comparison to sort of the EPA levels, you'll notice that in fact, there are some subtle differences in terms of what is collected and what is measured as well. And in particular, the correlation patterns are different than the AHRQ EPA-based variables, even though they might be getting at very similar measures for the neighborhood. And I will actually come back to thinking about this and contrasting the two in a little bit. But for now, I'm just going to focus on the fact that AHRQ has EPA variables in it. There are separate features that you can also layer in on top of that. And we're quite interested to see, well, how does it compare to one another? So here, I'm just going to show the best performance that we had from the previous couple slides ago, which is to think about if I look at the patient characteristics with the heart failure type with Charleston comorbidity, you'll notice that AUC is around 0.59. If I incorporate all of the HRQ variables, all 1,300 of them, I in fact can achieve comparable or better performance than the clinical characteristics alone. So I just want to highlight here, right? I'm not layering any patient characteristics. I'm simply just, passing into the model as features the 1,307 AHRQ variables, right? And for Blacks in particular, what you notice is that I, in fact, do much, much better. Well, maybe not much, much better, but I do quite a bit better in terms of predictive performance. Now, you can also see along the 5 different contexts, right? How it performs if I only look at those variables associated with those 5 different domains itself separately. And what you can notice is that social context matters more for Blacks, while economic context matters more for whites. But regardless, across the board, you can see this big difference in terms of looking at these effects are more predictive for Blacks than whites. And probably what we found more surprising, and what I want to say here is, EPA AQS, I'm showing that one. But if I only look at AHRQ's air quality variables as well, I get very similar performance. And so I'm just omitting it for simplicity. But in fact, air quality effects have higher predictive value than clinical comorbidities for Blacks, which we found a little bit surprising, right? And sort of teases out, well, maybe there's these other things that we really have to get at to better understand what effects are the environment actually playing on the outcomes themselves. Now, one of the downsides to thinking about air quality, right? So air quality is sort of understudied in the context of understanding the SDOH factors or looking at disparities. And there is a pretty good reason why. So what I'm showing you on the left-hand side is the EPA 15 variables before we did any median imputation. And then what I'm showing you on the right is also what is captured for AHRQ prior to any imputation that we're going to do. And in both cases, I am looking at roughly the same variable, right? So both of them are looking at PM 2.5. And what you'll notice, in fact, is EPA has a little bit more data than AHRQ, but not that much, right? So essentially what we need to do when we're thinking about incorporating air quality is how can you actually get at what are the likely measurements across these many, many counties where they're not measured. And I think that is still remains one of the big open questions that we're still sort of struggling or trying to figure out what might be good ways to get at what the value should be for these areas that we really know nothing about. So then one of the reasons, because AHRQ has census tract and county level features, we also thought, well, maybe we should see which one has more predictive value. And there was previous work looking at incorporating AHRQ variables in the context of MIMIC and some of the All of Us data set by Marziak-Assami's group. But what they found was that, in fact, there was very little difference between county and tract level. So it didn't matter which level you incorporated. Surprisingly, what we found is that it mattered quite a bit which level we looked at. And in particular, what you'll notice to make the analysis more even is that we looked at the intersection of features that were found both at the county level and at the tract level, right? Because what we found is county level actually has more features. And we really wanted to understand whether it was, because it has more features that it's doing better, or whether it was because the data that is collected is actually a little bit different between county and tract. And what we found is that, in fact, county level features perform better than tracts for Black patients, whereas tract variables are better for white patients. And this is just if we look at purely at the intersection. So it suggests that there are some differences in terms of what is collecting. Our natural inclination is to think, well, if I capture variables measures at the more fine grain, right, it should in fact help our predictive performance. This is in fact not what we have been discovering, at least for heart failure. And then there's, I want to highlight for thinking about social, economic, and education context, we in fact see considerable performance degradation when we use these tract level features. So even though we can, in fact, layer in tract level features, it seems that there is something that is being collected at the tract level that is making it noisier than thinking about it in the county level. And this is actually one of the other open questions that we're not quite sure of either why this is the case. And so this is something that we're actively looking into at the moment. But what I want to summarize, I think, in thinking about this first section and sort of laying the groundwork for the other three sections that are to come, SDOH features generally help Black patients more than white patients, which is not surprising given that neighborhood deprivation seems to have a higher correlation with adverse outcomes. Using a wider range of features from AHRQ can provide comparable performance to patient clinical characteristics. One of the things I didn't have time to touch on, which is that air quality features from EPA contains different information, yet actually provides marginal boosts if we layer it on top of AHRQ. And really there's questions as to why tract level performs worse than county level. And part of this is to discover, what is the difference between the two. Now, what I want to sort of summarize this first section, right, is that AHRQ still relies heavily on ACS, which is collected every 5 years, and in fact can have substantial missing data. So the natural question is, well, how can I get more dynamic measures of neighborhood? Can we get at it without asking the healthcare providers to collect neighborhood level information? So in other words, are there data streams that exist out there that we can tap into and think about leveraging that provide useful context for neighborhood without any healthcare provider having to solicit this information? And so there are, in fact, 4 different data streams that we think we can leverage in trying to capture these neighborhood level measures. So the first one is thinking about social media, thinking about Instagram, Facebook, and Twitter, although I guess many of you aren't on Twitter anymore. There's also geo-based services like Google Places, Foursquare, Yelp, and OpenStreetMaps. There's also mobility data that we can think of for Georgia and Atlanta. There's MARTA, which provides public transportation. There's the Department of Transportation that the US has. And also, Apple collects mobility trends that it releases here and there. And there's also community-based forums, which contain information about the neighborhood as well, but probably more focused on specific aspects of the neighborhood. And so examples of these would be like Nextdoor, Patient, like me, and Reddit. are prime examples of these community-based forms. So we first wanted to prototype and see, well, can these new measures actually be useful? And we're gonna, in fact, focus on 3 sources that have an API that we can crawl data from. One of them is Twitter, and I'm gonna note that this Twitter data was collected prior to Elon Musk taking over, OpenStreetMap, Foursquare. And what we're looking across these sources is we're looking at collecting points of interest or tweets within the census tract using geotags. And I noticed I think there's a new question. So if someone doesn't mind asking it, I'm happy to answer it in the context as well. All right, I'm just going to keep going then. And so I'm showing you examples of this information that we're sort of scraping from these different APIs. So Foursquare, we can get at, what's their rating, location. OpenStreetMap is the one on the right, which is showing you this park that we've been looking at and some of the information that OpenStreetMap has. And then Twitter, you can see a redacted version of the tweets that we can also capture. And what you can see below is also because they're geotagged, we in fact know where the location is. So in this case, they posted from Dunwoody, Georgia. Now, asking for all the data seems fairly impractical. And so what we focused on are in fact 6 environmental categories of interest. And much of this is based on existing literature that suggests that there are certain aspects of the neighborhood that may play a bigger part in a person's health outcomes. So this is looking at parks, which is access to green spaces, community engagement, connection with nature. We're also looking at pharmacies. So how easy is it to access medicine, refill your medicine, and get access to, sort of the healthcare professionals at the community level. We've also looked at grocery and restaurants, which are proxies for thinking about food deserts and food-related hardships that might exist. We've also looked at sports, which are things like gyms, physical activity, exercise. And then we've also been looking at healthcare access as well. So access to care, health information, and types of care. So we're looking at these 6 categories, looking at keywords within these 6 categories, and asking the APIs for geotag locations or tweets associated with these 6 categories. And in some cases, we've sort of expanded the keywords to reflect certain things within these categories as well. So the first thing I want to present is looking at the relatedness of the data streams. And so what we're going to do is a very simple measure of along these 6 different categories. Each source category is going to be normalized using the total counts. And what I'm going to say is that there are some census tracts that don't have many of these, if you think about rural areas, they may not have pharmacies or grocery stores. And so to avoid the zeros, we're going to smooth it with a little bit of noise under the hood. And then we're going to normalize for each source itself across the 6 categories. Then what we're going to calculate is a domain score for each category as the mean across the 3 sources. So OpenStreetMaps, Twitter, and Foursquare, we're just going to take the simple average across them. And then what we're going to do is we're going to compute the Pearson correlation between each source and this final category score. So what I'm showing you on the right, Pooja, do you have a question?
Yeah, but go ahead and finish this and I'll ask after.
Oh, no, because it's sort of like self-contained, so I'm happy to go either way.
Okay, just a question on the previous slide, which was, can you talk a little bit about how you identified the keywords for each of these categories? I'm assuming there aren't more standard terminologies or things like that, and or the way people talk about them might vary across the sources. So I was just curious how that process worked.
So for Foursquare and OpenStreetMap, many of them were standardized. And we, in fact, actually have been doing this on Google Places as well. So parks and pharmacy and grocery and restaurant and sports and health are relatively standardized. So for example, sports might be the more interesting one. There's like gyms, and there's also, like other parks that exist, indoor parks. And so we've been using those as categories. Now, Twitter is probably the harder one because there's less categorical evidence for it. And so what we did is we looked at reviews that are common or place descriptions that we would pull back from Foursquare and OpenStreetMap and Google Places. And then, so we would use the word itself and then find expansions of words that are commonly occurring in the descriptions for these places and use them as well. And in many cases, we erred on the side of a low recall rather than high recall in the hopes that it would give us better precision. So for like health example, we're looking at, clinics, doctors' offices, and I think hospitals are sort of the big 3 points that we're looking at. But it is something that, does need a little bit more refinement, but we basically erred on the side of if it was likely to be associated with the category, we would keep it. If there was any ambiguity, we would chunk it out.
Okay, thank you.
No problem. So then thinking about, sort of the information that is captured, what we can see is the alpha score is showing the overall correlation, average correlation across the sources, and a breakdown by each category. Probably the more interesting one is that pharmacies and restaurants tended to have higher correlations amongst the sources, whereas the other ones, they tended to be quite a bit lower. And so each source really does contain different points of interest and information. And that will be the subject of sort of the next section. But this is just to allude to the fact that there is discrepancy in terms of the information you pull back, even in thinking about these very refined, or maybe not refined, but these categories in general. So the first thing we looked at is looking at these final domain scores. What is actually the log odd ratios for thinking about 30-day readmission? And in the blue is the unadjusted, which means that it's just a raw score without thinking about the patient. And in the red is adjustment for patient characteristics as well. So this would be all the things that we had discussed as baseline features before. And what we see is that pharmacy and grocery have protective associations. That means that if you're near to more pharmacies and more groceries, in fact, your odds of being readmitted in 30 days are a little bit smaller. This is probably not very surprising to many of you, right? Because this means that you have access to food, you have access to medications, and so you're likely to take advantage of those access to get better outcomes. Now, the more surprising one is probably this one, which is thinking about restaurants. So restaurants, in fact, have a hazardous association with readmission, which we found extremely surprising. And usually whenever I present the slide, there are a lot of, surprised looks on everybody's faces, because you would think that, the more restaurants means that you actually don't live in a food desert, and access to food is actually much more natural, and so should have very similar effects thinking about grocery. Now, in fact, what we discovered, right, because this was a very surprising finding to us, is that when we looked into restaurants, more closely, what we found was places that have higher number of restaurants actually had more fast food restaurants. And what you're seeing here is a reflection of fast food, more fast food places, right? So if you think about, a community, fast food restaurants have very low footprint, right? And so I can in fact smush many more fast food restaurants together. Whereas if I have a, sort of a big sit down place, there will be less. And so inherently it was just capturing that correlation. And that is sort of what you're seeing here, which we thought was sort of interesting. But hopefully getting this also gives an idea as to why we pursued the fourth section of our talk. Now, in thinking about all of this, right, we also want to think about, well, what's the impact in terms of predicting 30-day heart failure overall, and then in thinking about Blacks, the Black patients versus the white patients. And so I'm repeating ADI and SCI aggregated at sort of the entire patient population, including another category. So there are patients who didn't identify as either Black or whites. And then I'm showing you sort of the difference in terms of the predicted performance of white adults minus Black adults. So negative means that the whites are doing worse. Positive means that white population is doing better. And what you can in fact see, right, is that overall, in looking at these novel data streams across the 6 categories, we in fact actually get much slightly better performance improvement over SDI and ADI. And I'm showing you just the characteristics themselves, right? So these SDOH factors by themselves, because what we find is when we integrate in patient clinical characteristics, the gap is, the trend is still there, but it's less noticeable. And so I just wanted to, highlight sort of the differences you see rather than having it being on a smaller scale. And then also, sort of the more surprising part for us is that there is less of an improvement for Black than white patients in looking across this, right? So you really see sort of an equalization in terms of roughly the same predictive impact across the board for both subpopulations. So in fact, disparities may not necessarily be widening. The only place where you would see this big difference is really looking at the Twitter data set, which, clearly is also questionable because there's a lot of things that can get pulled back and incorporated. So hopefully what I convinced you, right, is that it in fact is feasible to think about these non-traditional data sources for measuring neighborhood level SDOH factors. Simple aggregation of the data yields better performance than existing neighborhood-based census indices. And it actually provides a natural mechanism to dynamically adapt to abrupt changes in the neighborhood, right? Because a lot of this is user collected, and so you can quickly capture when things close and when things open. And so you don't have to rely on 5-year data that might be stale by the time you think about it. For rapidly booming environments, this is actually a very good thing. Now, one of the things that I might have alluded to, right, is that each of the sources identifies different points of interest, even in looking at the same geo-based services. So Foursquare and OpenStreetMap often slightly disagree on the places that exist. And so one natural question we had is, well, how can we quickly identify the same points of interest across the different data sources? And in particular, I want to motivate thinking about geospatial entity resolution. So in entity resolution, what we're looking to answer are whether two data entries from different sources like Google Places and Foursquare referring to the same real world object. And I'm going to give you an example in the context of, two pharmacies within a hospital in Atlanta. So you can see here, there's the medical center outpatient pharmacy, and there's also the Piedmont pharmacy. And the question that you're looking to answer in the context of geospatial entity resolution is whether or not these two refer to the same thing. And what that really means is if I have two tables, right, I'm looking to identify all the places where two things agree with one another. And what you can see are check marks of when they are looking at the same place, and also X if they're not referring to the same place. So in fact, for this example that I'm showing up above, these pharmacies are in fact different. But some of the difficulties you'll have in looking at entity resolution across the two sources is that I can have different names. And the latitude and longitude may differ slightly, right? And address may be the same or sometimes it's not. So it turns out that entity resolution is this essential process for thinking about integrating data across multiple sources. It's relatively well studied in database worlds, but the issue with it is that existing benchmarks fail to encompass rural areas. And so they really focus on the urban areas, and we're not sure how that translates to rural. And also the current state-of-the-art model, a machine learning model for this, requires that we derive this neighborhood representation, which needs to be retrained every time there are changes in the nearby neighborhood context. And what we'll show is that that's extremely computationally expensive in retraining. So I want to motivate this using a pharmacy nearby Emory. So this is CVS, which is a 2-minute block from our office in the Math and Science building at Emory. And you'll in fact notice that CVS is actually very poorly reviewed in this case, right? 2.8. But what we traditionally integrate into geospatial entity resolution is the information that you see right now. Now, in fact, it's actually very rich, right? If you think about Foursquare and Google Places and many of the other data sources like Yelp, in fact, many people provide reviews. And the natural question is, well, can I think about utilizing the reviews to actually improve the entity resolution process, so improve the accuracy of my models. So what we proposed is GeoRev, which is currently under review at the moment. But what we're looking at is to integrate 3 sources of information. So the first one is the transformer-based language model that takes the table representation that you saw a couple slides ago, and then calculates the similarity between the 2 entities. Another one is distance embedding. So I'm simply going to use Habersign distance to calculate how far apart, based on latitude and longitude, are these 2 entities that I'm trying to determine whether or not they're the same. And then the part that we're adding in is this review embedding. What we're going to do is we're going to summarize all the reviews and then concatenate them together using the SEP token in a transformer model. And what we're also going to do is we're also going to collect data from both rural and urban areas. And we're going to focus on 3 categories, which are pharmacy, restaurant, and grocery stores. We're going to focus on these 3 because they have the highest association, both positive and negative, to 30-day readmission. And what we do in the process of collecting all of the census tracts from Georgia is that we have the largest collection of retrieved entity pairs. And we're going to augment not only our data, but also existing benchmarks with the reviews. And what I'm showing you on the right is the statistics. So the top part is our new benchmark, and the bottom part is an existing benchmark that we're augmenting with the reviews that we have. So I'm first going to calculate, well, how good is the performance in terms of F1? So the top 2 rows here are existing entity resolution models that are standardly used without considering latitude and longitude. And so this is simply just using transformer-based models and looking across the different data sets. And then the last row is the running time it takes to train these models or to fine-tune these models, essentially. And you can notice that, Ditto is slightly longer running time than Deep Matcher, but provides better predictive performance in terms of F1. GeoER is the state-of-the-art geospatial entity resolution, which accounts for both the neighborhood context and the distance itself between 2 entities. And what you'll notice, in fact, is the running time is 250 minutes just to train it. And anytime there's updates to the neighborhood, you would actually have to rerun that process. And then what's highlighted is the last one. So we don't necessarily get the best performance across the board, but it in fact offers comparable performance when we incorporate reviews at half the training time to GeoER. And so if you're thinking about, sort of a computationally efficient way to get reasonable predictive performance in looking at determining whether 2 entities match, our model actually does quite well. So reviews, in fact, can be used to provide additional information about entities or points of interest. And our model, in fact, gets reasonable performance with substantial computational savings. It's robust to missing reviews. So, I sort of skimmed over it at the beginning, but about half of the entities may not have reviews. And it also doesn't require retraining when the neighborhood context for an entity changes. So this suggests that, we can start to integrate these different data sources together and get a better approximation of exactly how many pharmacies or how many restaurants are when we merge all these data sets together. And you might imagine that I can say, places that I see in multiple data sets, I'm more certain are still being used by many people, and they might carry higher weight. So rather than thinking about a simple aggregation, we can in fact explore much more complicated aggregation strategies. Now, what you'll notice is the 6 categories that we covered, in fact, were very, very broad. And so one of the questions that we really wanted to think about as well is, can we develop finer grained neighborhood level measures and how we might think about doing this? So let's take, for example, the restaurants, right? So we discovered that fast food is in fact more predictive, right, of this negative association we suspect. So how might we go about assessing this hypothesis and evaluating this hypothesis? So I'm going to use as motivation for this category refinement, looking at these 2 different tweets that we pulled back in the context of health healthcare facilities. So what you'll notice is the first tweet is looking at the name of the hospital and providing some masks. As you can tell, this was clearly collected during the COVID era. And then on the bottom right is somebody is posting about health insurance. Now, both of these are going to end up in the same category under our aggregation method. And the natural question we asked when we were looking at the data itself was, well, maybe they really don't belong to the same category, right? Because one is a proxy for thinking about hospital and providing some mass to the hospital, but the other one is really looking at health insurance, right? And a proxy for better understanding what's the insurance, whether many of the individuals in that neighborhood have insurance, maybe. So what we developed was a visual analytic system called Deep Twitch. And the intention was that it can be usable by ML experts, healthcare professionals, and policymakers. And the idea was that we wanted to be able to customize and spec and refine a topic model for the tweets using interactive clustering. And the hope was that in the process of integrating this human-guided refinement, we in fact can get a better health index downstream. So I'm going to, for the rest of this talk, focus on the health category itself, just to provide some intuition. But the idea is that, in theory, you could do this to any of the 6 categories or other text media as well. So the first thing we developed was a pre-processing tab, which is to think about removing redundant or irrelevant information when we're trying to build these topic models. And this includes things like hashtags, user tags, emojis, URLs, and a lot of duplicate information. So what we have are common patterns that you can easily remove as one pane. We have the ability to add custom regular expressions if we wanted to make things a little bit more flexible for advanced users. And then because we're adding this ability to think about regular expression and we want to make it accessible beyond just thinking about CS folks, it's helpful to preview what is actually getting removed in the context of some sample tweets. So what you see is, if the ats, right, are color-coded in pink, the hashtags are color-coded, I want to say in like this brownish yellow, and then the purple are these new URL custom regular expression that we've introduced. So this gives you an idea as to what's going to get pre-processed out of the tweet itself. And so the user can better understand, well, what are the choices I'm making to be included for the topic modeling or not. Now, the next step is actually to build topics. And what we thought is rather than thinking about the entire tweet and building a topic on that, we were just going to focus on keywords first. So what we're looking to do is extract important and relevant terms for each tweet. So an example from the 2 tweets that we had before, the keywords we would extract from the first tweet would be hospital, neutropenic fever, and cancer treatment. And then the second one is those 3 topics there. And what we wanted to do is we converted the keywords to word embeddings. We're using a very simple old embedding called Glove, but we explored with BERT and some of the other more advanced language models. And then we use affinity propagation to identify the topics. And what you see on the right are the different topics color-coded together. Now, some of them didn't make sense. And so from the, I realized that it's like 1:54, so I sort of want to make sure that I managed to get to the end. We use contrastive learning to integrate in human-guided knowledge. And what that means is that a user provides an anchor, a positive, and negative keywords. And the idea is that we would push, anchor and positive together and anchor and negative further apart. What that means in terms of thinking about this interactive clustering is that we would have topics using the extracted keywords on the left. We have the user input to provide the keyword triplet. So in this case, they're annotating risk, ridiculous, and disease to be, so risk and ridiculous should be further apart, and disease and risk should be closer together in the context of the keyword. And then what you see here is also keeping track of the constraints that have been added. So we did a preliminary study of this dashboard. for 17 census tracts and 824 patients. And what we found is that if we compare it to SDI, you'll see that that is a score using just SDI. If we use just the course health score, so the domain, the aggregated version, in fact we get 0.533. If we try to refine it using just the basic topic model affinity propagation without any user input, you in fact are no better than SDI. And if we add about 13 or 14 constraints, we in fact get this better health index. It's not necessarily better, but there is improvement. And the question is, well, does this really extend broadly? And so what we introduced with Deep Twitch is this interactive system that can help us get at finer grained neighborhood level measures. And this iterative process really helps, healthcare providers and policymakers give us feedback as to what might be reasonable topics or not. So I'm going to quickly summarize, sort of the 4 big points that I hope you took away, right? Which is that it's beneficial to incorporate more neighborhood level measures. We in fact can think beyond non-traditional data sources to capture neighborhood level measures. If I want to think about these different modalities, I also want to get at, how I can deduplicate them or identify unique entities. And so you might want to think about entity resolution. And then finer grained measures may require systems to capture domain knowledge. Now, I want to tease some of the ongoing work that is going on or that is planned. And one of them, in the middle is really, we're looking to pilot specific pharmacy interventions for patients not living near pharmacies. We're thinking about, so this is in conjunction with the pharmacy fellows and also cardiology fellows at the moment. We have an IRB written up and the hope is to get this off the ground probably in January. But we can also think of, many different sources of information to capture the spatial, temporal, and measurement correlations, better understand why county and census are different, and also layering in more rich information as well. And with that, I want to thank my collaborators who have done all the hard work, and they're all shown there, as well as NIH, NSF, and J&J for their, funding my group's work. And I'm happy to take any questions, that are left.
Questions from folks online? Oh, great. Awesome. Shalmali?
Hey, Joyce, thank you for the great talk. I was curious about the entity resolutions. Like how robust would the model be on like feature changes happening at the end of the data sources, like Google Maps changes something about their features or APIs, and then how do you deal with that?
So what I presented was probably the idea that we can align features across different databases. And that is a common thing that's done in database. What I didn't get to present today was, in fact, it's really sensitive to alignment. So I, in fact, had to define this shared schema model. And my grad school, actually, I should say my postdoc, Jing, has work that shows, how we can integrate and do this alignment in the context of incorrect alignment. So if you add new data streams, like we would automatically learn which ones should be aligned together and take that into account. In the context of geospatial, it doesn't do much better because most of them return the same thing at the moment. But we do have sort of algorithms and models that work broadly. Yeah.
Amazing.
Hi, and then
Sorry.
Hi, I'm curious, when you were looking at the SDOH databases and all of that information, I know that the census was conducted during the pandemic and that there was probably a lot of implications of the data being collected during that time. And also when you were looking at like EPA measures, there was probably a lot of differences in air quality due to the pandemic as well. Did you see any of those effects in your models when you were looking at those, or did you examine them at all?
So the funny thing is, actually, we don't see the COVID level effects. And what I sort of hid under the hood is that we have data from 2010 to 2018 for heart failure. And what we did is we aligned to whatever SDOH, the closest year for that index hospitalization. So in other words, like we don't see the, sort of the effects of COVID. In fact, we're just aligning to the nearest year. So all the data will be slightly different depending on when you got hospitalized.
Thank you.
Yeah, go ahead.
Since ADI and SDI as three news sources are all measurements on the neighborhood environment, for Black and white patients, traditional indexes such as ADI and SDI has better performance on Black and white person, while the new features like squares and tweets have better performance on white than Black. Can you give me some possible reasons why we have this kind of difference?
Yeah, so it's especially for Twitter, it's a little bit surprising. I think with the other data sources, it's less prominent of a difference. And our hypothesis with Twitter is that probably the user base is more centered around the white population, like they just tend to tweet more. And so naturally the tweets are predominantly coming from that population. With that said, we because of the way we collected the data, there's no way for us to ascertain whether or not this is, what's the race and gender for the person tweeting itself. And so that is simply just a hypothesis. Given that Twitter has sort of changed its data collection policy, I suspect that we can't quite go back and examine it anymore because all of these tweets will have gone away. But that's sort of our hypothesis as to why, for Twitter especially, you see white population having a better impact than Blacks. But with the other ones, the difference is less noticeable.